He is a programs director at Partners in Hope in Malawi, and he's providing strategic leadership to a large PEPFAR or Department of State supported HIV care and treatment program, managing over 207,000 persons living with HIV on antiretroviral therapy. Before working at PIH or Partners in Hope, Dr. Phiri was executive director of Lighthouse Trust in Malawi, over 20 years managing PEPFAR and CDC care and treatment program with over 170,000 persons living with HIV on antiretroviral therapy. He's an accomplished implementation scientist with a large body of published work in areas of PMTCT, which is the prevention of mother-to-child transmission of HIV, and Malawi has made amazing strides there. HIV, TB, non-communicable disease integration, so bringing in the non-communicable disease piece. His interests include HIV treatment and care, operational research in infectious diseases, and in particular sexually transmitted infections, HIV and AIDS, and TB. Dr. Phiri received a master's degree from the University of London, London School of Hygiene and Tropical Medicine, and the University College of London, and was awarded a PhD in clinical epidemiology from University of London, the London School of Hygiene and Tropical Medicine. Dr. Phiri is a professor in the Department of Medicine at the University of Carolina School of Medicine in Chapel Hill, the Department of Global Health at the University of Washington in Seattle, and professor at Kamuzu University of Health Sciences in Lilongwe, Malawi. We are so lucky to have Dr. Phiri today, and I will pass it over to you.
Thanks, Tracy. So let me bring up the presentation and make sure that I have the right one.
Absolutely. Take your time.
Yeah, let me see.
Something is starting.
Yeah.
There we are.
Good, thank you. So you just confirm you are able to see the full slide presentation.
Yes.
And you're able to hear me well too.
Yes.
So thanks, Tracy, for that's quite a generous introduction. It is always a pleasure for me to do this lecture. And we're talking about global health, and I'm using the global health partnerships, for example, that we have using the use case for Partners in Hope, HIV care and treatment program, and with other universities in the US, but in this case with the University of California, Los Angeles. And we'll be going through the presentation today just to look at the HIV and AIDS global update up to the end of December 2024, look at the Malawi HIV national response, and then look at the Partners in Hope, the program update, and just add in some integration of non-communicable diseases in a routine HIV care. And then finalize with, in this case, the role of partnerships in program and the implementation science in that case. So in that case, for now, what I do is globally, so this is actually like a 2023 global picture of, in this case, HIV burden. And just to emphasize that the bulk of the burden is within the African region, mainly also in the Eastern and Southern Africa, which is up to 21 million. But when you add up 20 and 25 and 26, you get up quite significantly close to 28 million within the African region in that case. So looking at end of December 2025, looking at the global HIV epidemic, estimated about 41 million people living with HIV globally. And that's about 1.3 million new infections and about 630 HIV-related deaths. So this is quite a significant component. And as we've been talking for global and also for Malawi, once these are once you're having a good program globally on this would reduce, and also this will reduce, and we'll be looking at that as we're doing the presentation. This is just to show, once again, as I mentioned, I show you the 2023 picture, but this one is actually the 2024 picture, the latest update, whereby 65% of the burden is within the African region, with the 26 million out of, in that case, the 41 million that we looked at. So in this case, you know that the burden is where, unfortunately, where little money, where the healthcare is not as strong, that's where the burden of the disease is. This has an implication too when I talk about foreign assistance later on, because the countries who are here, I don't think that they will be in a position to manage their burden without foreign assistance. This is a slide just to show you from, let's say, 1990, as we're talking about early 90s, as we're going up to 1995, that's when the ability of antiretroviral drugs, AZT, started in the US. So that had an impact on the number of new infections. As you can see that here, they were above 3 million. But then when you talk about 2024, that's about 1.3 million. And then when you look at the blue, here the solid blue is the number of HIV-related deaths, which were basically above close to 2 million in, for example, 2004, but about 630,000 in 2024. So this is just to give a picture of how the HIV burden was between 1995 and 2000, and then to look at what the picture's been as we're looking at from 2015 to 2024. All this is because of the scale up of treatment programs, including antiretroviral drugs. And the USG program, the PEPFAR program, has a significant impact on this. And then I'll show you what it will mean here if we do not pay attention, and if the funding cuts would continue as over that. Now, in terms of HIV treatment cascade, we're looking at the number of people who actually know, the percentage of people living with HIV who know their HIV status, and then percentage of people living with HIV who know their status and are started on antiretroviral drugs, and then percentage of people on antiretroviral drugs who have a suppressed viral load. So the blue bar is the number of people who know their status. The orange bar is for those actually, so the green bar, sorry, is for those, and then the orange bar is for those who know their status and started on treatment, while the green bar is actually number of people who know their status, they're on treatment, and they are fully suppressed in that case. So when you look at this globally, you see that the target is 95%, 95%, 95%. And this was targeted for, in that case, for 2030, and to make sure that 1990 was coming up to 2025 or so. So in this case, you see that it is 87, 89, 94 versus the 95, 95 target. Now, these are the regions, and the sitting basically in that case, where you, in this case, where I am, Eastern and Southern Africa, where the main burden is, reassuringly, it is basically above what the global is. That's 93, 91, 95, which is reassuring. And all this is also because of the foreign assistance that has come in over that. And I thought that you'll be able to look at, in that case, in other components over that period. Now, this is to look at the groups that was to look at the females. So women, they've been doing very well, 92, 83, 79 globally, while for males, it's 84, 73, 69. Now, in this case, men actually health-seeking behavior, they've seen that is lower compared to their female counterparts. But also, as you know, when a woman is sick, they go to hospital, and when a child is sick, they go to hospital. If a spouse is sick, they go to hospital. If a neighbor is sick, especially in Africa, they will also go to hospital. So because their exposure to the health facilities is higher, they are more likely to have access to HIV testing, and therefore that's why they would be likely to be tested earlier and their outcomes are better compared to their male counterparts. However, children 0 to 14 years, you realize that it is 63, 55, 47. These are lower. And globally, we need to pay attention to children. And because if the women are doing better, why are they not bringing their children to the health facilities? So as medical students, those of you who are in this class and they are thinking about global health, now you look at what are the strategies that should be put into place in order to do this. This is already a PhD thesis that you can work on before even you get your MD at this component in time. So I just wanted to motivate you. There's a lot of work here globally that you can work on in order to have the children to make sure that they are matching up with their adult counterparts. This is a busy slide, but I just wanted to let you know that there are countries who have gone beyond towards the 95. And I show this because I know that Malawi is part of that with the 95, 90, and 86, which is pretty much a good progress towards the 95. And then when you get the slide deck, you can be able to study those on track and those actually who are making progress but not on track, and those who are off track. For example, Afghanistan, Bangladesh, some of these countries have their war zone actually areas in that component. But you study this when you get the slide deck in a bit more. But I'm very proud to see that Malawi is marked as, and then Botswana, Eswatini, Lesotho, Namibia, Rwanda, Zambia, and all these are Southern African countries. And this is also where the high burden of HIV is. For example, Botswana, Eswatini, you're talking about a prevalence of above 30% in that case. Looking at prevention of vertical transmission of HIV, just to mention that from 2010, whereby the coverage of prevention of vertical transmission was only 50%. The good news is that currently the coverage of that is above 80%, at 80%. So as you know, if you have a good accurate coverage of prevention of vertical transmission, you have the women who are going to be healthy, because 60% of the HIV positive cohorts are women, and especially in Southern Africa. So which means that if your coverage is above 80%, you'd have healthy women. They are also less likely to transmit to their children, because in most cases in Sub-Saharan Africa, the fertility rate is above 6%, which is 6 per household in that case. Now, this one I just wanted to show you in terms of what is if we do well in terms of number of people put on treatment over a period of time. When you started, for example, in 1990 to 2024, you realize here that now the number of AIDS-related deaths, which were higher between 2001 and 2007, the more you put people on treatment, then because it's treatment as prevention, the less accurate AIDS-related death happen. So as you can see over here, whereby you were basically up to, in this case, up to probably 2 million AIDS-related deaths, but now coming up, as we saw, 630,000 AIDS-related deaths. The target for 2025 is here, so we are missing the mark over here, but pretty much we've done really very well over that. Now, coming up, as I said, with all this progress that is happening, with all this progress, you realize that the impact of funding cuts on HIV epidemic control gains. And as you know, with the US new administrations in January, then PEPFAR, foreign assistance, in this case, PEPFAR was affected with a stop work orders, which I'll talk in detail later on. But just to mention that globally, it is expected now that in terms of new infections, these are basically whereby we are getting about 1.3. You realize that this is 2024, whereby this gain over here that we are going down for 2030, we're supposed to be reaching around here. But with what is happening with the funding cuts, then we are going to surge up and we are going to go, this would be almost as going back to almost in the 90s. It will be a shame if actually that is going to happen. Similarly, when you have actually reduced actually effort on people on treatment, when the new infections are going higher, at the same time, we will have also more actually AIDS-related deaths, which are going to be equivalent to what is between 2000 and 2008, or even higher, which is going to be a shame to have actually these programs to go back and lose the gains that we have. So I just wanted to give you a picture of not only in this case for United States government, but also we've seen cuts in Europe, like in Germany and the United Kingdom. We've seen cuts. The Global Fund has not been replenished as expected. So that global cut of funding would have an implication on this. These are the key indicators of actually that trouble is brewing with the current status. I hope that we are moving together while now we land into Malawi. So Malawi, HIV burden and response. So we are landlocked, bordered by Tanzania in the northern part, and then we are bordered by Zambia and Mozambique in the eastern part, and then Mozambique in the, in the western part, Zambia and Mozambique, and in the eastern part we have Mozambique, and also in the southern part we have Mozambique. So this is actually Malawi, which has the northern region, central region, and southern region. The burden of HIV is higher in the southern region because it is also highly populated. It's a high density, but also we have a lot of establishment of sugar plantations, tea estates, coffee plantations, but also along the lakeshore over here, the HIV burden is also higher. So Malawi actually put up a 2020-2025 strategic plan for HIV, and with pillars in there, and with progress, like gains and accelerating progress towards epidemic control. And these are the key attributes to the goal, to make sure that we have a free HIV/AIDS generation, 2025 moving to 2030, and also high quality prevention, treatment, care, and support, making sure that we are contributing towards ending AIDS as a public health threat in Malawi by 2030. And the overall objectives, making sure that the new infections from 2020 move from 34,000 to 11,000 in 2025. And then making sure that we reduce AIDS-related morbidity and mortality, but also reaching the 95 treatment targets. And I'm pleased that, as I showed you already, we'll see later on, this we've really done very well. and of course, improving overall management of HIV services, including resilience, healthcare, and social welfare. So this one, when you look at it, looks busy, but just look at the solid red line from 1984 when it was actually 85, it was when it was identified over here with these estimates in terms of the number of people, size similar to the last year's estimates, people who are alive, people living with HIV. It has been over a period of time with treatment, decline in new infections, high mortality, improved ART coverage in around 2012 when the universal prevention of vertical transmission was included, test and treat was included 2016. So here it is estimated that in 2024, Malawi has about 991,000 people living with HIV with an annual decline of 0.6%. So this is just to show in terms of the number of people who are living with HIV in Malawi as of December 2024. This one is looking at new infections. And as we can see, like the global, it was higher in the early 90s. But then you see that is less than, in this case, 10,000. In 2025, it was a target over there. So 70% fewer new infections amongst women than in 2023. So you remember we said from 34,000 to 11,000 in 2025, but 2024, you had seen that it was already below actually 10,000 in that case. And this one is new infections in males, more than 15%. This one is a little bit higher, but you see that it was about fewer by 70% in 2024. Just to mention, it was peaking in the early 90s, but we've really done very well when you look at 2024 in that case. And then here, new infections on children, and we realize that around 2,200 infections in 2024. This is what we are seeing here. These were basically higher, up to about 25,000 in 2005. Now, this one is HIV-infected pregnant women. In the early, like mid-90s, they were basically over 70,000, but now about 30,000 in that case. And this is the majority of our cohort. The Malawi cohort, 60% of people living with HIV are basically women in that case. So as you can see, the mid-90s, over 70,000, but in 2024, about 30,000. Now, coming up to ART coverage, treatment on adults 15 years and above, it was really, when the program started in 2005, 2007, it was basically at 20%, but currently in 2024 is at 92%. So there's a 92% coverage of people who are expected to be on antiretroviral drugs. Out of the 991, we have about 932 who are on treatment in that case. So this one is coverage for children. This one, you remember I said this is a PhD project. You see that you are coming from a coverage of 92% for adults above 15, but you have a coverage of 58% for actually children 0 to 14 years. So we need to pay more attention. That's where you put on your global health hat to make sure that we work on pushing this up to basically closer to 90%. And then, so this one is looking at final transmission. So testing for children who are born from HIV positive women at 24 months. What is the HIV-free survival? And in Malawi, out of 2024, it was about 6.7%. So that's shy by 1.7% to reach to 5%, which is a threshold for elimination of vertical transmission. So we need to be here to make sure that we are awarded like a gold for the elimination of vertical transmission for this. Our colleagues in Cuba were able to get this in that component. So this one is just to look at 2022, the number of people who estimated, and then 95, this was what was available there. In 2023, these were estimated. This was the 95 one was like this. Now, out of our current estimate, 2024, you realize that we've reached the 95, which is really, I try to make sure that you clap hands on your own for Malawi for making this progress. However, we're coming back. So for women, it's similarly, then for men, there's that difference which I showed you for global. Similarly, you see that for children, for Malawi, it's 76, 77, 84. Still, we require to put more attention to children to make sure that we match up with the adult counterparts. So this is really a worry, and we need to work on this as a program. So the key message here is that as of June 2025, there were 13,000, about 14,000 people, new infections were identified, and then 14,517 were started on treatment. So as of 30th of June, Malawi had 932,936 people living with HIV alive on antiretroviral drugs. And this is 92% of the ones who should be on treatment, with a gap of 8%. And for pregnant women and breastfeeding women, retention at 6 months was at 81%. But when you look at the general population at 12 months, the general cohort, it was 78% for children and then 78% for adults. These are areas now, although the 95, the children are lower, but the retention is actually equivalent when you look at adults and children in this case. So the key message, pregnant and breastfeeding women, you see that 81%, and this is so around 80% retention for both, with a 92% for coverage. With lessons from the stop work order and termination of programs in Malawi due to the 2701, that's what we call it, 27 January 2025. So we know that many HIV services and systems currently are donor dependent. And so staffing, logistics, and technical support, and then fragile data systems for ART, and then viral load monitoring chain has many weaknesses. So therefore, we need to make sure that we manage that. So MOH may currently not be able to sustain the gains. That's true. We may even reduce may and say MOH currently, Ministry of Health, cannot sustain the gains without the foreign assistance. And then we try to look at defining the core HIV services that can be done with impact and a cost-effective way, and then requiring to utilize available resources to prepare for the off-ramp. So in this case, when the foreign assistance was taken away. So I think what we do now is zipping into Partners in Hope as a program, as a use case, as I am going to be winding up the discussion. So we have the HIV program under the previously it was USAID, but we moved from 1st of July to the State Department. So our foreign assistance, our programs, we have HIV program and the TB program. All these are up to June 2026. We do actually support 9 districts, and these are across the country, 2 in the north, 4 in the center, and 3 in the south. And then 123 facilities in there. And basically, we're talking about 204,794. These were 207,000 in January. but because of the stop work order and termination, we've declined to 204,000, and I'll show you a little bit later on. So the call was to look at increasing and to sustain the proportion of people living with HIV, and also increasing durable viral load suppression and the high impact preventive services, which is pre-exposure prophylaxis, and improving availability of quality site level data. So this is what actually Partners in Hope has gone through, and it has gone through, I can as well say, tough times. You can still say we can gone through hell. In January, and stop work order, suspension of the program. A waiver for life saving was given on 5th February. However, unfortunately, on 27 February, our Partners in Hope program was terminated, and therefore, Partners in Hope had to lay off about 1,000 staff, giving them their benefits, and therefore, which means from February to early June, Partners in Hope program was not available in the 123 sites in the 9 districts. However, on 21st of March, the termination was rescinded, and therefore we had to go again to recruit staff, but all on a reduced portfolio. In this case, because of the mechanism capacity, about 919 staff, and this we're able now to go back to the facilities from June. So in terms of how from June, the program after now coming back, how have we been doing? This is a dashboard just to show what we call tracer indicators. So in this case, the number of people who are tested on the program, we expect from October 2024 to August 2025, that's about 11 months. We should be 92% of the PEPFAR targets, the global targets for Partners in Hope. And then so we're able to test 728,000. And then we are able to find 11,000 positives. And we're able to put 11,000 people on treatment. And as I said, 204,794 as a cohort. While pre-exposure prophylaxis, we expected to put on 18,000, but we have 6,995 because according to life-saving guidance on PEPFAR, we are only supposed to provide on this program pre-exposure prophylaxis to pregnant and breastfeeding women, not the general population. So that's why we have this. And then screening for women living with HIV for cervical cancer. As you know, cervical cancer HIV is a high risk. So women living with HIV have a higher risk of getting cervical cancer. So we screen them, and we are able to screen 33,000 against the 35,000 we are supposed to screen by end of September. So we've been doing very well on the dashboard, except the pre-exposure prophylaxis, because we are restricted not to provide to the general population who are at risk, but only pregnant women. Now, how has the stop work order funding cut impacted on the program? So as you can see, the number of people living with HIV on treatment under the Partners in Hope program, you realize that from October 2023, we had 204,000. As of December 2024, we had 207,940. However, from January to March, and then coming from April to June, there's this reduction. This is the period I said from February up to basically early June. The staff under Partners in Hope were not in the facilities, 123 facilities. However, when we got a rescission of the program, then in June, we were able to recruit the people back into the facilities. And now we are equivalent of what we had here. And we expect that we should reach up to here in the coming 2 quarters in this case. So this is to show you what happens if there's no accurate support provided through the program. Let's look at HIV testing. You realize that we're testing close to basically, in this case, over 80,000 in that case over this period in a month or so. But as we can see, from February to May, we were able actually to go down over that. Similarly, for finding people who are positive, we were able to find over 1,000 people living with HIV to be found positive. But you see here, February, March, and April and May, we were getting below 1,000 because I should say they were getting below 1,000 because we were not in the facilities. But you see, when we recruited the staff back, Partners in Hope, then we are back now up to where we are going with about over 1,000. So this is showing you, this is what you get with a foreign assistance. And then, but I would like to say that if the foreign assistance is not there, the Malawi program will still be operational, but actually there will be a reduction in, as you can see over here, 42% and 25% reduction in testing and finding positives, respectively, on the program. And here we are looking at the people, this is the people who are lost to follow-up. When the program is running, when the program of Partners in Hope was running, we had only about a 3% lost to follow-up in our program. But during this period, that loss to follow-up went up to about 5%, including to come up to closer to 6% over here. And if I show you basically from July to August, this has already started to go down as a recovery. So this is a sign to say that much as the program will continue to be operational, you see that the loss to follow-up, because there are no mechanisms and also poor documentation, then this would be a challenge whereby we'll lose. And this is explained by the number of people living with HIV. So this is to look at tuberculosis, identification of tuberculosis amongst people living with HIV. We're getting around 2.7% when we were running up to that. But as you see, during the period when the program was terminated, there was a reduction in identification. So the HIV TB program under the ministry was running, but the effort was less. Look here, after now the teams have come back, then you will see that the TB program was not terminated, but after a stop work order, it had resumed around April. That's why you see that recovery started earlier compared to the HIV program. So with that, just a few slides on integrating non-communicable diseases. And I will have to do that in the coming less than 10 minutes to allow about some discussion. So integrating non-communicable diseases in routine HIV care. So non-infectious diseases have emerged as a leading cause of death amongst older HIV positive individuals. The important risk factor for cardiovascular diseases are obesity, smoking, hypertension, diabetes, and dyslipidemia. So HIV infection itself may cause inflammatory activation in the blood, leading to accelerated vessel aging and increased arteriosclerotic plaques. So in that case, we're talking about the process of national efforts for integrated HIV NCD care in Malawi from 2007 up to current process. And there have been efforts from the ministry, including guideline development and plus platforms. And then there was a policy guidance on screening in ART clinics, including from 2016. And currently, this is being implemented in the facilities. And it is more where the implementing partners like Partners in Hope are doing. And this is just to emphasize that the success of HIV programs with millions of people living with HIV now living longer is being undercut by the escalating burden on NCDs. So the emphasis, the potential impact is that enhancement of HIV and NCD service delivery can not only help people live with HIV to live longer, healthier lives, but can also leverage resources whereby non-infected people can benefit from resources available for HIV programs. So leveraging in HIV care investment for non-communicable diseases. So this is just a sign from our Partners in Hope and UCLA collaboration, whereby looking at rates of uncontrollable blood pressure in Malawian adults living with HIV, and this is within the cohort at Partners in Hope. So the idea was to characterize rates of and factors associated with blood pressure, and then looking at a prospective observational cohort with a blood pressure of systolic of about more than 140 over 90, and then looking at controlled hypertension, which is less than that, and then antihypertensive non-adherence score, which was self-report of missed doses at each visit. There are about 158 participants, and 23% were on antihypertensive medication, and then, of course, over 60% were females. 19% of these achieved blood pressure control over the year follow-up, but we've seen that in the program, this has gone up even above 70%. The conclusion from this study was that adults living with HIV and hypertension had low rates of blood pressure control over 1 year, associated with self-reported non-adherence to antihypertensive medication. So what you're saying is that interventions to improve blood pressure control are needed to prevent associated long-term cardio and cardiovascular, cerebrovascular morbidity and mortality. And with Dr. Lisa Hoffman and team, we're working on a program to look at this at our Partners in Hope Center of Excellence to address these. So HIV and NCDs integration, there's tension between differentiated care models because currently we provide antiretroviral drugs up to 6 months, but then for the hypertension, this care is provided in probably a month or 2. So the idea is to make sure that even if someone has 6 months supply of antiretroviral drugs, they have to come back to the clinic to pick up medication for antihypertensives. So as I said, with Prof. Lisa and team, we are working on making sure that we synchronize the antihypertensives with antiretrovirals. And availability of blood pressure measuring devices should be able to support. And then usefulness of screening for other diseases, for example, diabetes and hyperlipidemia is clearly not only useful with access to adequate treatment in that case. So we leverage the successful HIV clinic structures for our as a chronic other diseases like diabetes, asthma, and also hypertension, and then normalization of HIV as a chronic disease. So, partnership. So as you heard, of alignment with University of North Carolina and Chapel Hill. I've done a lot of work there, Malawi Cancer Consortium, NIH-funded projects, the University of Washington, but more importantly for now, with the teams, as you can see, Lisa Hoffman here, Dr. Karina Mucharad from University of New York University, and this collaboration is very significant, and we've done a lot of work together in that case, which is for this. So, with Lisa and Kate, we have a program called Respond, which looks at the last mile for HIV control from the Gates Foundation. Kupewa, which is a vernacular word of prevention in this case, and this one is an HIV and human papilloma virus vaccination and cervical cancer screening amongst HIV positive adolescents and young women. And then we have also Choice, which is looking at programming within also which populations we should be able to focus on. And then, so this one is Dr. Corina Mucharad and Lisa, Dr. Lisa Hoffman and myself are co-peers. Here, Dr. Catherine Dovell, myself, and Kevin co-peers. Here, we have Lisa and Dr. Choko, Kate and Dr. Choko are co-peers. While this one, we have, in this case, Dr. Margaret, who is actually has this from NIH. So it says collaboration partnerships are done properly, and it is a success in that component. And probably we have not really done badly as partners in Hope to do this process in that. So I think that's a lot for now, and that was a marathon. My expectation is that we were able to follow. We looked at the global burden for HIV. We looked at the burden for HIV in Malawi. We looked at our Partners in Hope for HIV management as a use case, and also the impact of the funding cuts for global and also for Partners in Hope, like here in Malawi, and also the partnership of Partners in Hope with the University of California, Los Angeles, and also New York University through Dr. Karina Mochaland. The slide deck would be available through Tracy for you to go deeper into the discussion of this component. Otherwise, thank you for listening, and it has been a pleasure to present to you. And back to you in this case, Faisal.
Thanks so much, Sam. I appreciate it. It was a great talk, and I'm happy to. We have a little bit of time for questions from. You're getting lots of claps, you can see on the screen. We're happy to have questions from the students. And in the meantime, if while we're waiting for one, Sam, I'm curious what your hypothesis is about the discrepancy between children and adults. That's not just true in Malawi, but just sort of globally in terms of detecting their status and then also getting them on treatment successfully.
Yeah, it's really, that's why I said it's really a big thing, because we've looked at it. Because what I say is children, in this case 0 to 14, at least the under fives, we expect that these are so their mothers or their caregivers should be able to bring them, and most of them will be on treatment too, so we expect that they should bring. But actually what we realize is that when they move into up to now from 9 years to about 14 years, most of these now would be like in schools. Some of them might go into boarding schools. So we expect that over there, in terms of access to care, is less supervised. And also, even for those who are on treatment, you realize that because of stigma and how they can be able to be taking the medication long term at a boarding school, it can be an issue. But even for the less than 5 years or so, we realize that women, as this comes to providers too, I usually emphasize to providers to say that when a woman is in front of you and they are HIV positive, you're providing treatment, you should be able to ask to say, how old is your last children? Do you have a child less than 19 years? Have they been tested? That is not probably done also by providers. That's how we are missing. Or are you breastfeeding? Do you have a under 5? That's important too.
Yeah, thanks, Sam. That makes sense. Questions from any of the students?
Probably that's a sign that whatever was presented did not make sense anyway. Right?
Oh, that's not true. This is a great group of students. They're very engaged, and we're very fortunate to have them so interested. And so I think that they are probably
I acknowledge
understood.
that it is quite a lot, and once the team gets the slide deck, Tracy, I am open if people would like to ask questions, even off the Zoom after they have digested the slide deck.
Yeah, of course.
I have a question.
Great, Astrid. Go ahead.
So you mentioned there were some discrepancies in losing patients to follow-up. do you have like mechanisms in which you regain contact with those patients, or like how you go back out and remake that contact later?
Thank you. So currently, what we call treatment continuity programming, what we do is we make sure that we front load the messages of the importance of while you have started on treatment to remain on it. So in the first 6 months, we allocate all patients started on treatment to what we call case managers. They are called treatment supporters who provide counseling every time they come to the facility to make sure that they are retained in care. When they have missed their appointment at 7 days, when they were expected to come, they have missed. Then we also do, before they come in for the day, we have 48 hours. Within 48 hours, we do reminders to say that you are supposed to come to the clinic in the coming 48 hours. When they have missed their appointment by 7 days, we also do reminders either by phone but then tracing is physical is done at 28 days. So we make sure that we do the phone, or if we don't get them on the phone, we now trace them, and we have people go out on either push bikes or motorbikes because we do locator maps for them. So that's because we have a capacity to do that as an implementing partner. When we were off the facilities, the government does not have that capacity for now. So that's why there was that component. So when we went back, we generated a list of each one of the one who is supposed to come but did not come. So we are now following them up. That's why you see that there's a recovery of that component. Thank you.
Thank you.
I see a question in the chat, Sam. It's from OAB. It says, how would the recent political changes in Malawi affect this progress, and how do you adapt and navigate the changing political landscape in general? That's a big question for you, Sam.
Yeah. It's a big question, but I think I'm able to answer it. I cannot predict, but one thing I can tell you is that Malawi has been so lucky. When the HIV program, so Malawi got the global fund round one, about 200 million in 2002. And so the HIV program was consolidated because the health service in Malawi is free unless you decide to go to a private clinic. And for HIV services, they are free even if you go to a private clinic. So from 2004, that's where the public health HIV program was instituted. So the Global Fund putting in all the drugs are 100% on Global Fund. Then operationalization of support is actually from PEPFAR and other donors. What I can tell you is that Malawi has been lucky that from 2004 to 2009, 2009 to about and then 2012, there was a change, 2004 to 2009, then change in 2012 for a government, then change in 2014, change in 2020, then a change now. For all the changes that the governments have done, the HIV program, especially looking at the money, has not been tampered. So even if you hear about corruption and all that, which is available here and there, and corruption is not only for Malawi, most countries have that, I'm sure that side too, but only the HIV program, that has not been touched. So we've been so lucky that all the governments that have come in have not actually tampered with the HIV programming money. So we expect that probably that trend will continue, but I cannot predict. But my expectation is that because the technical people in the government are the same, so they should be able to advise that for us to maintain the gains, we need to have this. So the political will and support has maintained regardless of the differences of the governments.
Thanks, Sam.
So there's do you see a world where global health efforts can lead to self-sustenance in under-resourced nation as a global health practitioner, what sort of program should we aim to design and advocate for the health of? So that's right. That's a good question. So technically, what I usually say is, I said this in March when I was on a panel in San Francisco at CROI, when it was put up. I said the decisions that were made in January in the US, there are components actually which are there, and so Americans first, and then the domestic components over that, and then foreign assistance, like international countries should look at. So I think there's some, when the census is coming over there, there's an issue of that it was abrupt, so a soft landing, because already countries, for example, in Malawi, in the last 2 years with PEPFAR, we've been working on a sustainability framework plan to look at what roles should the Malawi government should take for now, so that we do technical assistance. So the service delivery to be done directly by the government, and then technical assistance. But in terms of the drugs, because they're expensive, for now, they would still be bought under Global Fund. So currently, I also acknowledge that our governments could have started already to put in a little bit more. But now we are working on it. Actually, we were just in a meeting last Friday where we are looking at the sustainability framework to look at what are the must-do activities on the program. For example, when you talk about the funds and tracing, it might be difficult for the government to do. So we are listing up what are the activities that can be done with less money that probably the governments, including Malawi, could do. So as a health practitioner, what I'll say is list up what are the activities that can sustain the gains, and then the governments to start contributing part of the 15% budget cap for health in African countries, the measure for HIV, and then the foreign assistance can be able to start to supplement and complement and support whatever is available there. So there are some activities that we can do, but there are other activities that we can only do when we have foreign assistance. So that's what I would say for now. And I'm discussing, and when I'm on a platform with the government of Malawi teams, I advocate for what the government can do easily, or stretching towards that. But also when I'm on a platform to lobby for foreign assistance, I don't think that Malawi can do all of it without foreign assistance. So the foreign assistance should still be incorporated. So the global health, I think that has been adopted for now for the USG, would be able to support that technical assistance to support the national programming. That's what I would say for now.
Thanks, Sam. Appreciate it. Mindful of the time. And again, thank you so much for taking the time in your afternoon. I know how busy you are, and we're grateful for your partnership and your collegiality and your willingness to share your great work with our students. And I'm sure that hopefully you'll be hearing from some of them who are inspired to work and learn from you in the future. So thanks again, Sam, and I'll look forward to seeing you in person next time. Okay?
Thank you very much. Thanks, Akesara, and thanks, Trace, and thanks everyone for making time early in the morning to come to this lecture. Thank you, and
Okay.
all the best.